Hello.
Hello, ma'am.
Sheba, Elizabeth is stuck somewhere. I think we can start.
Okay, ma'am.
You can start presenting.
Good evening, everyone. Good evening, ma'am.
Good evening.
Presenting the case of a 65-year-old lady who presented with complaints of gradual, progressive, painless diminution of vision both eye for the past 2 years. No history of any flashes of light or floaters. No history of redness, eye pain, watering, photophobia, or colored halos. No history of headache, nausea, or vomiting. No history
1
of
minute.
any.
Can you put it on slideshow?
Is it visible, ma'am?
No, it's not on slideshow. You can see in your place a slideshow.
Yes, ma'am.
Then you present.
No history of headache, nausea, or vomiting. No history of any trauma. No history of any difficulty in crossing the roads, walking on steps, or walking on uneven ground. No difficulty in recognizing faces or seeing objects from the side. No history of any difficulty in walking after the dark. No history of tripping over objects or bumping into objects. She is able to read newspaper with spectacles. Past ocular history. She is using spectacles for the past 2 years and last
So what is
changed.
there relevant in the present ocular history? What was her first complaint?
Diminution of vision, madam. Gradual, progressive, painless diminution of vision.
Okay. Was there any associated findings or associated complaints?
No, madam. Just the diminution of vision she was complaining of.
Okay. There's no history of colored halos at all.
Yes, ma'am. No history.
Okay. Any what else do we ask in the history if you are suspecting glaucoma?
If there is any eye pain, watering.
That is an angle closure glaucoma. What if the characteristic complaint that usually comes for a patient who's being diagnosed with primary open angle glaucoma?
Difficult to see objects that is coming from the sides.
That is in the advanced cases. That is in advanced cases.
Frequent change of spectacles.
Yeah, frequent change of spectacles. So usually people come like that in this presbyopic age, saying that they had to change their glasses frequently. That is the time when we have to suspect whether they have checked their intraocular pressure. So if there is a frequent change of spectacles, what else will we suspect?
Cataract.
Yeah, you can check. You have to doubt whether of cataract. Then
if there is any retinitis pigmentosa.
Retinitis pigmentosa, characteristically, they will say night blindness is there.
Yes.
So what are the causes of gradual progressive painless loss of vision?
First one is cataract,
Yeah.
and then glaucoma.
Yeah.
Then retinal pathologies like macular hole. Then conditions like chronic retinal detachment.
Chronic retinal detachment. What is that?
Retinal detachment for.
Retinal detachment is a classic cause for sudden painless loss of vision. So this is a gradual painless loss of vision. So usually in this age group, first thing we have to consider is cataract only.
Cataract.
So to rule out a cataract from your history, what else we can ask? Another complaint is glare occurs for such patients if it is an early cataract.
Yes.
Like due to the nucleus sclerosis or due to the posterior subcapsular element, they can get glare. If they are people who do night work, they will say specifically about that. Okay, so and in cataract, if it's due to a nuclear cataract, you will have frequent change of glasses spectacles. Then you have to consider glaucoma. So in glaucoma, if it is a open angle glaucoma, usually patients will not have any history of colored halos, but they can have the history of change of glasses. Then the third most common cause is, especially in this age group, a non-communicable disease that can cause change of
diabetic retinopathy.
Yeah, other than retinopathy, due to the fluctuations in sugar, you can get refractive changes. That you have heard, no? When the
Yes,
glycemic
stats.
status changes, the refractive power also can change. So
Change.
that is one common cause. And then you come to the diabetic retinopathy. You come to the diabetic retinopathy. So in diabetic retinopathy, what can be associated complaints along with this? Like they had a painless loss of vision. They can get a history of positive scotomas. Like if there is macular edema or if there is vitreous hemorrhage, there can be a history of positive scotomas, either during reading or during distant vision. So now in this one, you are given the no history of flashes, floaters, redness, eye pain. So by ruling out the redness, eye pain, watering, photophobia, what all we are ruling out actually?
The painful causes of
You are
diminution of
ruling out
vision.
the painful cause. So maybe that you don't need to present in the beginning itself. You
Yes.
can present towards the second stage. Headache, nausea, vomiting, all are causes for painful loss of vision.
Loss of vision.
Okay, next slide. Okay, so this is a negative history for an advanced glaucoma. So you can include some of these points also. That is, if the patient has got, like if he has already lost vision in one eye and he is going on to lose vision in the other eye only, he will understand these things. Okay. Okay, next slide.
Past ocular history. She is using spectacles for the past 2 years and last changed 6 months ago. She is on topical eye drops, that is eye drop Timolol 1 drop BD both eye and on eye drop Travoprost 1 drop HS both eye. No history of any ocular surgery or trauma. No history of lasers or injection. No history of any topical corticosteroid use.
So what are the causes? This ocular trauma you have given, ocular trauma and surgery. So does ocular trauma cause any conditions that cause a progressive loss of vision?
Yes, trauma can result in traumatic cataract. It may result in traumatic cataract. Then this
Is traumatic cataract progressive?
no, it occurs at an earlier age than normal, but it is not progressive.
It progresses actually. It will start you have heard about reduplicated cataract. That is one type of cataract that starts in one layer and later some clear transparent fibers come and then over on top of that another cataract comes. That is reduplicated cataract. Otherwise also the cataract due to blunt trauma can progress. Then any other cause of decreased vision due to ocular trauma that can present after several years?
Angle recession.
Yeah, angle recession glaucoma. That is one point that we usually miss out. Then no history of surgery. What surgeries can cause decreased vision?
Like any intraocular surgeries for retinal detachment or other conditions like retinal pathologies, surgeries for any retinal pathologies or any refractive surgeries in the past.
Okay. No history of any topical steroid use. Why you have given that history?
Topical steroid use can result in glaucoma, long-term use, which may present with painless diminution of vision.
Which are the conditions where such an elderly lady will be using steroids, topical steroids?
Topical skin creams and
skin creams, okay.
Then for joint pains and all, they may take systemic steroids like joint pains, osteoarthritis and all.
Okay. What of in the eye? Do you give topical steroids for elderly females? Have you given? I have given. Any condition?
A cataract, post-cataract steroids.
This lady has no history of cataracts.
Cataract. Okay.
Meibomianitis or blepharitis, a usual condition where they are given topical steroids for long term.
Okay.
Okay, next slide.
Past systemic history. She is a known case of systemic hypertension for 10 years and type 2 diabetes mellitus for the past 8 years. She was diagnosed with dyslipidemia 1 year ago. She is on regular medication, tab metformin 500 mg twice a day and tab amlodipine 5 mg twice a day. There is no history of any cardiovascular diseases, chronic kidney diseases, cerebrovascular accidents, bronchial asthma or thyroid disorders. No history of any joint pains or corticosteroid use. No history of any migraine. Personal history. She consumes a mixed diet, sleep and appetite normal, bowel and bladder habits regular, no addictions, no history of any drug allergy. Then no relevant family history. Coming to the ocular examination. Unaided visual acuity is 6/18 in the right eye and 6/18 in the left eye, which is measured with Snellen's visual acuity chart at a distance of 6 meters, with pinhole right eye improving to 6.9 and left eye improving to 6.6, with a best corrected visual acuity of 6/9 in right eye and 6/6 in left eye. Near vision, she is N6 with +3 diopter sphere in both eyes. Head posture is normal, no facial asymmetry, orthophoric gaze, extraocular movements, ductions and versions were full in all directions.
So you have not done the dilated retinoscopy?
Yes, ma'am, that is given along with the dilated fundus examination.
Oh, okay. So what is the refraction that you have shown? 1.25, 20 degree. This is the first time she's using glasses or she was
No,
using
ma'am,
this
she
power?
was using glasses since 2 years.
2 years. This
2
power.
years. Not this power. Now this is the power.
Okay. So what is the refraction that she has now?
This shows astigmatism is there.
What
Then
type of astigmatism?
compound astigmatism.
Right eye? What type of astigmatism?
Simple astigmatism.
Simple astigmatism. What is that? What are the types of astigmatism? This whole she has got power along only one axis, right? It's the right eye. And left eye she has got power along both axes. So that you will see in the dilated retinoscopy. Okay, continue.
Head posture normal, no facial asymmetry, orthophoric gaze, extraocular movements, ductions and versions were full in all directions. Anterior segment examination of the right eye, lids were normal in position, margins normal, skin over the lids normal, eyelashes normal, palpebral aperture normal in width and height, lacrimal apparatus normal, rhoplast negative, conjunctiva normal, cornea normal in shape and transparency, corneal sensations intact. Anterior chamber, Van Herring's grade 4 with no cells or glare. Iris shows normal color and pattern, no new vessels. Pupils, single round 3 mm, reacting to both direct and consensual light reflex, no RAPD. Lens, nuclear sclerosis grade 2 and cortical cataract. Anterior vitreous normal. In the left eye.
1 minute. What is the Van Herring's grading?
Van Herring's grading, it is the grading to assess the depth of the anterior chamber. In this, the patient is made to sit in front of the slit lamp and the light beam is adjusted in a 60-degree angle so that one beam will fall on the cornea and the other in the iris. And we will assess the depth between these two beams. If the width of that is equivalent to that of the corneal thickness, then that is Van Herring's grade 4. If it is half or 1/4 to half of the thickness of the cornea, it is grade 3. It is less than 1/4 and less than half, grade 2. Then less than 1/4, it is grade 1. Then the Van Herring's grade 2 less than 2 is indicative of narrow angle, and we are supposed to do gonioscopy for that patient.
Okay. Next slide.
Left eye, lids normal in position, margins normal, skin over the lids normal, eyelashes normal, palpebral aperture normal in width and height, lacrimal apparatus normal, rhoplast negative. Conjunctiva normal, cornea transparency, normal in shape and transparency, sensations intact. Anterior chamber, Van Herrick's grade 4, no cells or flare, normal color and pattern of the iris, pupil single round 3 mm, reacting to both direct and consensual light rays, no RIPD. Lens, nuclear sclerosis grade 2 and cortical cataract, anterior vitreous normal. Intraocular pressure, right eye it is 16 millimeters of mercury and left eye 14 millimeters of mercury measured with Goldman sublimation tonometer at 10:20 a.m. on eye drop Timolol 1 drop BD both eye and Travoprost 1 drop HS both eye. As per her records, the earlier IOP was, pre-treatment IOP was 26 millimeters of mercury in the right eye and 24 millimeters in the left eye.
How long back?
1 year ago, ma'am. Then gonioscopy of the right eye done with Sussman 4-mirror lens. It was grade 6 in all 4 quadrants according to the RPC system of grading. No NBA was seen. In the left eye also done with Sussman 4-mirror lens. All the 4 quadrants 6 according to RPC system of grading. No NBA.
Okay, just say that grading RPC center.
RP center system of grading. It is a gonioscopic grading. Here we have got 6 grade. Grade 0, there is no dipping of the light beam. In grade 1, there is a dipping of the light beam. In grade 2, Schwalbe's line and anterior 1/3 of the trabecular meshwork is visible. And grade 3, middle 1/3 of the trabecular meshwork is seen. Grade 4, posterior 1/3 of the trabecular meshwork is seen. Grade 5, it is scleral spur, and grade 6, ciliary body band is seen.
Okay. When you are assessing the angle, what all structures do we have to look out for?
From anterior to posterior, we have to look at the Schwalbe's line, the trabecular meshwork, the scleral spur, and the ciliary body band. If we are seeing the trabecular meshwork up to the posterior trabecular meshwork, then that is indicative of an open angle.
Any other structures we can see normally behind them? This lady, did she have any other structures? She didn't have any other structures. Any abnormal pigments?
A Sampolesis line or
Yeah, I mean, normally what we can see, what are the structures we can see? Sample SC is an abnormal finding, right? Any other structures normally you can see?
Pigmentation of the trabecular meshwork can be seen.
Trabecular meshwork.
Then iris processes can be seen.
Yeah. So how will you identify whether it is pathological or not, whether the iris process is pathological, whether it is anterior synechial?
It can be the iris synechiae will have a lacy pattern, whereas the
synechias which can be mistaken for iris processes. They can be fine synechiae. They are fine. If the peripheral anterior synechiae could be either broad-based or it could be fine. So if it is an angle closure glaucoma, usually it is a broad-based peripheral anterior synechiae. So this fine peripheral anterior synechiae, how do we differentiate from the iris process? Is based on the position where it is inserting. So this peripheral anterior synechiae, usually it will be seen to cross the scleral spur. But the iris process do not cross the scleral spur. And normally, do we see any blood vessels?
Normally, blood vessels will not be seen.
Normally, you can see, even you can see blood in the Schlem's canal if you are applying inadvertent pressure. Yeah, when you are doing, especially when you are doing with the Sussman, if you are applying inadvertent pressure, you might be able to see the blood in the Schlem's canal. In which all conditions we can get an abnormal pigmentation present in the gonium?
In case of pseudo exfoliation, then for pseudo phakic conditions or aphakic conditions, then history of any past uveitis,
trauma,
Ah.
then nevus of aorta, you get pigmentations. Then if you're seeing especially in a diabetic patient who is not having any control, you should also look out for NV8. So in this patient particularly, she has been having diabetes for 8 years. So when you're doing
Yes, ma'am.
gonio, you have to look out for NV8 also.
Mhm.
Is there any condition where you use this gonio other than diagnosis of glaucoma?
We can differentiate between angle closure, that is a positional angle closure, or synovial angle closure by doing a
Using
gonioscopy.
by doing gonioscopy. What type of gonioscopy is that called?
Indentation gonios.
Indentation gonioscopy. And any other? So you can use it for the diagnosis of glaucoma. You can help in the differentiating whether it is open angle or closed angle. Then what are the
Uh,
conditions you need gonio?
In case of trauma, to find out is there any foreign body which is in the trabecular meshwork or
Very
in
good.
the angle structures.
Okay.
Then in case of this,
And also you need in the diagnosis of some other conditions like
a few
you can get neoplasms in the angle. So if you have doubt like that also you can use. Then in surgery, post filtration surgery, what all do we check in gonio? You need to see the internal ostium that you can see with the gonio. Then with the peripheral iridotomy also you can see clearly with the gonio. Then it is also used in the diagnosis of another slit lamp condition, which usually we check on the slit lamp. If you have a doubt, we look into the gonio. What is that? A young male coming with which one?
Fuse. In case of fuse.
Fuchs, what do we get? Danceless lincoln. Fuchs heterochromic iridocyclitis.
Yes, ma'am.
What is the gonio finding? I don't know. New vessels, huh? I'm not sure of that. So there is a condition where in young males, when they come with abnormal movements and liver problems, you sometimes on slit lamp you have a doubt, you check into the
KF.
bone. Yeah,
In
KF
case
ring.
of KF
KF ring.
rings.
It helps in the diagnosis of KF ring. Then you can use gonio therapeutically for a therapeutic procedure. What is that? Which laser procedure we need the help of gonio?
Trabeculotomy, gonio assisted.
Trabeculoplasty. Trabeculoplasty. In trabeculoplasty, where is the laser? Where do we hit the laser in trabeculoplasty?
Near the root of the iris.
It should not cross the root of iris. It is between the pigmented and the non-pigmented trabecular tissue. So that is what you need to know about gonio. So, what are the types of gonio?
Direct gonioscopy and indirect gonioscopy.
Okay.
And direct
you have used direct or indirect?
Indirect.
You have used indirect. Why is it called an indirect gonioscope? So you should know the principle of gonio. Yeah. What is the principle of gonio?
The light which is falling, interference of the light which is falling on the air corneal interfaces, usually it is reflected back. Here there is internal reflection of the light falling on the air corneal interface is eliminated with the gonio lens.
Yeah, so normally you have an internal reflection of the light, but when you place the gonio lens over there, from the opposite angle, it hits the gonio mirror and it falls into our eyes. So that is the principle of an indirect gonio lens. What of a direct gonio lens? What do we use over there? We are using a prism. So you're directly visualizing the angle. There is no inversion over there. So what are the examples of indirect gonio lens?
Indirect gonio lens, Goldman, then Sees, which includes Sussman, Posner. All these are indirect.
Okay, which is a handheld gonio lens?
Posner,
Paathsaala.
which
Okay.
is
What is the difference between the Sussman and the Goldman gonio? You have
it
seen
is
the
a
Goldman gonio, right?
yes, ma'am. The Goldman, there is single mirror, 2 mirror, and 3 mirror gonioscope is there. Here in Sussman, there are 4 mirrors are there, and it is the difference in the arrangement of the lens. In Goldman 3 mirror, 2 lenses are aligned to see the fundus and one to see the ankle structures. But in this, all the 4 are tilted in some 64 degree to see the ankle structures.
Okay, any other difference?
In Goldman 3 mirror, we have to use the visco
Yeah,
substance
the curvature of that lens is different.
more.
Yeah,
But
so you
here,
need to use the visco coupling
uh,
fluid in the case of
here
Goldman.
the
But
tear film of the patient itself acts as the coupling fluid in
Yeah.
case of Sussman.
Sussman. So another therapeutic use of a Sussman is to break an acute attack. So when a patient comes with an acute attack, you can use the Sussman for indentation to open up the angles. That is another use. Okay, next slide. Okay, your favorite topic. So what is it? What is this retinoscopy image show?
The
Right
dilated
eye.
right eye showing an acceptance of plus 1.25 in the 20-degree axis.
Based on your retinoscopy, what is the refraction that you're getting? What is the distance and what is the cycloplegical percent?
Retinoscopy done using tropicamide 0.8% at a 1 meter working distance.
1 meter. So what is the correction that you have given to the patient for this retinoscopy?
1.5.
So is it 1 meter?
1.5.
It is not 1.5. You are giving a correction of 1.5 in this use step. Two-third meter. Two-third meter. So, okay, you're giving minus 1.5, minus 1.5. 2.75 minus 1.5 etra.
1.25.
1.25 and the axis is 20 degree.
20 degree.
So what type of astigmatism is this?
Right.
This is regular. Regular means it should be 90 and 180. Then how can you call it regular? What else is there? Oblique. Huh? It is an oblique astigmatism. Simple oblique astigmatism. Simple hypermetropic oblique astigmatism. Left eye?
Left eye also simple.
No, both axes are having hypermetropic refraction. So it is it mixed, compound or simple?
It is compound.
It is a compound hypermetropic oblique astigmatism. Okay, this all you should know. They will ask you for your exam. Retinoscopy is a favorite topic for all exams. And all your cases, if possible, you should do the retinoscopy also. If they give you a dilated patient, you can easily do the retinoscopy. Okay, next one.
Dilated fundus examination of the right eye, which was done using a 70-80 lens, and the pupil diameter was dilated was 7 millimeter. Distant direct ophthalmoscopy showed a good red glow with peripheral spoke-like opacities. Disc color, size, shape, vertically oval, normal sized disc, which was measuring about 1.8 millimeter vertically, and the cup measuring 1.4 millimeter vertically. It has got a distinct disc margin. Inferior rim less than superior rim. NRR thinning was noted inferiorly. No disc hemorrhages or collaterals. CD ratio was 0.8, bionetting, bearing of vessel, and laminar dot sign noted. Arteriovenous ratio was 2/3. Macula normal, FR not seen. Examination with red-free filter showed diffuse RNFL. In the left eye, the pupil dilatation was 7 millimeter and
Okay, 1 minute, just take the right eye again. So based on the distant direct ophthalmoscopy, do you think cataract is significant or not?
not that significant.
But the vision is improving only till 6/9, right?
Maybe the peripheral spoke-like opacities is obscuring the view in undilated state.
So that's what I asked. In the distant direct, you'll be able to understand if it is coming towards center or not. So most probably your improvement of vision is not complete because of the early cataract. So maybe there is some significance for that cataract. Then how did you measure the length of the disc?
I measured it using the slit lamp biomicroscopy and a 78D lens. The patient was made to sit in front of a slit lamp, and the graticule of the slit lamp is adjusted in such a way that the scleral rim is first taken and it is measured. Then the cup size is also measured using the same. And since I used a 78D lens, a correction factor of 1.1 was given, and hence the CD ratio was calculated.
Okay. So if you're using a 90D lens, how much correction we have to use?
1.3. We have to use a factor 1.3.
1.3. Okay. So based on this, your cup disc ratio has come to 0.8.
0.8.
Okay. What is this ISINT rule?
What is?
ISNT rule.
Normally the inferior rim, the thickness of the inferior rim is more than superior, more than nasal, more than temporal. But in glaucomatous cases, this ISNT rule is not obeyed. That is, there will be change in the thickness of the different places of the rim. That is ISNT.
So what is the normal shape of the disc?
Normally,
normal shape of this disc and cup.
Vertically oval disc with a horizontally oval disc. That's the normal shape of the disc.
So what all points do we have to check, especially when you're evaluating a disc when you're suspicious of glaucoma?
First of all, we have to measure the size of the disc. That is the scleral, we have to measure the size of the optic disc and that of the cup, because in case of large optic disc, large optic cup is a normal finding. So the second one is the neuroretinal rim. We have to see the thickness of the neuroretinal rim in all around the optic disc. Then we have to see the vascular changes.
Before you go to the vascular, anything else you have to note in the
we have
peripapillary
atrophy.
No, in the neuroretinal rim. The neuroretinal rim is the most important thing you have to examine, right?
Yes.
That is why we are using a 78D to have a better magnification. So what all we have to check in this neuroretinal rim?
The thickness of the neuroretinal rim. Then the color.
Color is very important. Why is it important?
Because the color is given by the capillaries, and the reddish hue is given by the capillaries and the supporting cells in this neuroretinal rim. So whenever there is a loss of the neuroretinal rim, there will be this color will also be lost.
Actually, you have to differentiate between the neurological cupping and the glaucomatous cupping. So if it is a neurological cupping, what will happen to the color? Pallor
will be more than cupping in case of neurological.
Pallor has to be noted. So it is very important because there are several conditions that can mimic a glaucoma. So always you have to understand the color of the neuroretinal. That is very important. Anything else you have to assess in the neuroretinal?
The ISNT.
ISNT rule. And if you are looking out for the ISNT rule, you have to check for a focal defects. You have to check for the notching. focal defects in the neuroretinal rim.
Neuroretinal
Anything
rim.
else? Unless you note these points in your mind, you will not check it. That's why it is important. So always we think of ISNT rule, but that is only in some cases of glaucoma where there is thinning of the inferior superior limb. So first thing you have to check is, it's not like every case that has got a large CD ratio or a CD asymmetry will be glaucoma. So you have to, the first thing you have to is understand whether the patient has a glaucoma or a non-glaucomatous cupping. So for that, you have to look into the neuroretinal. So in the neuroretinal rim, one thing is the size, shape, color, then focal notching. Then what is? One more important thing is that. One thing that will help you understand whether there is any progress in the glaucoma. What is that? Is normally seen most commonly in the supratemporal area.
And hemorrhages.
Yeah.
Presence of any disc hemorrhages.
Disc hemorrhages. That is very extremely important. That is called Drans hemorrhage.
Drans hemorrhages.
Drans hemorrhage. What is the importance of this Drans hemorrhage?
In case this trans hemorrhage is most commonly seen in case of normal tension glaucomas. So when
How
a
does
patient,
it occur?
because of the decreased perfusion of the optic nerve head.
Because of the loss of the ganglion cells over there, what happens is the blood vessels have a hemorrhage. Because of loss of support of that, the blood vessels bleed over there. That's what happens. And it all shows that there is a progression in there. After the hemorrhages absorb, you will see the defect over there. So that is another thing you should look out in the neuroretinal rim. Then after that, you go into the cup. So what all changes you should see, look out in the cup?
First is the change in the shape of the cup. Normal cup is usually horizontally oval, but in case of glaucomatous cupping, there will be which becomes vertically oval. Then as the cup becomes deep, we can see laminar dot sign. That is the fenestrations of the lamina fibrosa become more prominent. Then we can see the other vascular thing like bearing of the subclinear vessels, bionetting of the vessels. The bearing is because as the cup recedes, it lost its support, and hence we can see a bare area between the neuroretinal rim and the vessel. Then because of the double kinking of the vessel, we can get a bionetting sign.
Is that an old change or a recent change?
Can be an old change.
It is an old change. Can you give me a new vascular change due to the sudden loss of support of the neural tissue? What happens to the vessel? Overpass of the vessels. That is sudden straightening of the vessel. That is the overpass. That is a recent change. So all these you have to check in the differences in the cupping. Okay. Now the next important thing is the peripapillary area. Why is the examination of the peripapillary area important?
In case of glaucomatous changes, we can see the peripapillary atrophy can be seen, which has got two zones, that is the alpha zone and beta zone. Alpha zone is seen away from the disc. It is because of the changes in the RP layers. Then this is the beta zone. As the thickness of the beta zone increases, it is an indication for the thinning of the neuroretinal rim.
So why is it important in glaucoma examination?
Because sometimes in case we may have the tilted disc or topped disc in that conditions to assess glaucoma in such cases.
Yeah, actually, if it is in myopia or if it where you can be tilted discs, or in some conditions where there is already a pre-existing peripapillary atrophy, the importance is you have to be able to identify the margin of the scleral cup. So in some cases, we might make a mistake. That is the most important thing. You will think that the peripapillary area is actually the disc.
Scleral rim.
Yeah, it's actually the disc. So you will put down your cup disc ratio as 0.3 or 0.4, while actually that is not the area. So always when you are assessing the optic disc, you should, first thing is you have to be able to draw correctly, which is a disc and which is a cup and which is the peripapillary area. So that is the importance in taking the photograph. So unless we have the photograph, we won't be able to correctly assess. That's why in glaucoma, they say the fundus photo is very important, especially the optic disc. That's why I had asked you. Only then we can understand whether it is corresponding or not. So which of this peripapillary atrophy is more specific for glaucoma?
That a beta zone, increase in the beta zone
Yeah,
is
increase
more
in the
characteristic of glaucoma.
beta zones. Okay, so now we have what you need to assess is the neuroretinal rim, then the cup, the peripapillary area, the vascular changes. Then what else we have to check out?
RNFL defect.
Yeah, the
We have to check.
RNFL defects are very important. So normally, what is the arrangement of this RNFL corresponding to the optic nerve head?
The fibers which are seen more periphery in the retinal layer is coming more superficial in the optic nerve and vice versa.
Superficial ആണോ deep ആണോ പെരിഫറിയിൽ ഉള്ളത്? Optic nerve ഹെഡിനകത്തോട്ട് വരുമ്പോഴത്തേക്ക്
it is more deep. Periphery is more deep. Deep
periphery
in
is
the
more
optic
deep.
nerve. In the optic nerve.
ചിന്തിച്ച് ആലോചിച്ച് you told the reverse. So you should have that image of the picture. Periphery എന്നുള്ള ഫൈബേഴ്സ് എല്ലാം ഡീപ്പ് ആയിട്ടാ പോകുന്നത്. ആൻഡ് സെൻട്രി എന്നുള്ളതാണ് സൂപ്പർഫിഷ്യൽ ആയിട്ട് പോകുന്നത്. ദാറ്റ് ഇസ് സെൻട്രൽ. Then what else? From the optic nerve head to which part of the retina it will go?
To the fovea as papillomacular bundle. It goes to the fovea as papillomacular bundle, and from the temporal periphery it go arcuate and goes to the optic disc.
Yeah.
And
So that is the importance. From the temporal periphery, it forms arcuate fibers to the superior and the inferior corresponding areas. But what about the nasal? From the nasal
also,
part, the nasal part, it just goes directly and gets attached to the nasal margin of the optic nerve head. But actually, arcuate fibers are formed in the temporal fibers. So what is the importance of that when you are looking out for the RNFL defects? So if you're getting a defect in the neuroretinal rim supratemporally, you have to check which part of the RNFL area.
Infronasal.
No. You have to check that curved fibers. അവിടുന്ന് superiorly curve ചെയ്ത് പോകുന്നതാണ് നോക്കേണ്ടത്. മറ്റേ nasal part of the optic nerve head ആണെങ്കിൽ അവിടുന്ന് സ്ട്രെയിറ്റ് പോകുന്ന ഫൈബേഴ്സിന്റെ അവിടെയാണ് നമ്മൾ RNFL നോക്കേണ്ടത്. അപ്പൊ നോർമലി എങ്ങനെ, how do you see this RNFL defects?
It can be seen as slit-shaped, wedge-shaped, or diffuse defects. Usually
normally.
Slit or wedge-shaped defect.
Wedge is actually an abnormal finding. So
Slit
how
defect.
Yes, horse striations in our end, that is a normal one. So what happens to the blood vessels when wedge defects occur? അതിന്റെ അടുത്തുള്ള blood vessels കുറച്ചുകൂടെ straighter ആയിട്ട് പോകും because അവർക്ക് support ഇല്ല. That is how we are differentiating. And what is the best way of examination of this red free filter? Examination of RNFL.
Examination using red free filter.
Yeah, when you are examining the red free filter, you will be able to see the darker RNFL defects as dark wedge shaped or diffuse defects. So this much things only if we look in detail, you can actually complete your examination. And why do you think this is a normal shaped disc, normal size disc?
Size of the disc is normal. Yes.
Don't you think it's in the larger, because 1.5 okay ആണ് normal എന്ന് പറയുന്നത്. So this is a towards the larger side. It's a large cup. 1.8 and large disc, sorry, 1.8 and the cup is 1.4. So it could come in the criteria of a large cup and large disc. But the higher retinoscopy shows hypermetropia. So in hypermetropia, you are not actually expecting a large cup. You are expecting a large cup in a myopic patient. So there is some contradiction between the two. Who did the retinoscopy?
I did with the help of refractionist.
Which retinoscope did you use? Which one you used? How many retinoscopes are there?
Dry retinoscopy and wet retinoscopy.
Dry retinoscopy and wet retinoscopy. What is dry retinoscopy?
That is done using undilated fundus and undilated when the pupil is undilated.
Okay. So you did a dry or a wet?
Wet retinoscopy after dilated.
Okay. Which retinoscope is used? How many retinoscopes are there? Plain mirror retinoscope and streak retinoscope. Two types of retinoscopes. All this you should know. Usually, both are available in the hospitals. Some hospitals only streak is there. So you should see the streak retinoscope and how to use it. Okay, left eye.
Left eye, the pupil dilatation is 7 mm. Distant direct ophthalmoscopy shows good red glow with peripheral spoke-like opacities. Disc is vertically oval, normal-sized disc measuring 1.8 mm and cup measuring 1.4 mm with distinct disc margin. Inferior rim equal to superior rim. No disc hemorrhages or collaterals noted. CD ratio was 0.8. Bionetting, bearing of vessels and lamina dot sign was present. Arteriovenous ratio was 2/3. Macula was normal. FR was not seen. And examination using red-free filter showed diffuse RNFL defect.
Okay, so does this RNFL defect correspond with the damage to the NRR in both the eyes?
In the right eye, it is not corresponding because since there is a thinning in the inferior part of the neuroretinal rim, we expect a defect in that quadrant. But here we show it as a diffuse defect.
Okay. You are able to take the fundus for, no, you are not able to take. Then only we can understand correctly. Okay, why do we get this vertically now elongation of the cup in glaucoma?
Because of the loss of the this neuroretinal rim.
Vertically. For that, you should know the structure of the lamina. How many holes are there? Like, how is arrangement of the holes?
Round towards the as round in the periphery. As it moves towards the center, it becomes oval fenestrations.
Actually, the superior and inferior part of the lamina has got larger holes. So these they are exposed to more damage because the larger axons are passing through it. It's exposed to more of raised intraocular pressure, and there is more damage along the superior and the inferior. That is the answer. Why do we get more glaucomatous damage along the vertical planes? Okay, now next slide.
In direct ophthalmoscopy using 20D lens, both eyes showed tessellated background and visualized periphery was within normal limits. So the summary, 65-year-old female, known case of systemic hypertension, diabetes mellitus and dyslipidemia, presented with complaints of gradual progressive painless diminution of vision in both eyes of 2 years duration. She is on topical anti-glaucoma medications. On examination, the best corrected visual acuity was 6/9 N6 in the right eye and 6/6 N6 in the left eye. Anterior segment examination, both eyes showed nuclear sclerosis grade 2 with cortical cataract. On dilated fundus examination, both eyes showed a 0.8 cupping with inferior rim less than superior rim in the right eye and inferior rim equal to superior rim in the left eye with characteristic bionetting, bearing of vessels and lamina dot sign. Diffuse RNFL defect noted in both eyes with red-free filter. Diagnosis, primary open-angle glaucoma, both eye nuclear sclerosis grade 2 with cortical cataract, systemic hypertension, type 2 diabetes mellitus and dyslipidemia.
So what is the importance of the systemic diseases in glaucoma?
The systemic diseases like hypertension, diabetes, thyroid, etc. are risk factors for development of this primary open-angle glaucoma.
Why is the history of hypertension important?
because two reasons are there. First one is that the over treatment of the hypertension in some cases may result in the nocturnal hypotension, which may result in the hypoperfusion of the optic disc, which may further cause damage. Then another reason is that if we have got a patient with glaucoma and if she is on systemic beta blockers as treatment, we have to take caution while giving medications for the glaucoma.
So which drugs was this patient taking?
Patient was taking amlodipine for the systemic hypertension.
What is the mode of action of amlodipine?
Calcium channel block.
Calcium channel. So it is not a problem for this patient. Okay. What changes do you expect in the patient if she has 8 years of diabetes?
We are expecting diabetic retinopathy changes in the fundus examination.
What is the first change of diabetic retinopathy fundus?
Presence of dot Henry.
No. First change. Diabetics vaicilla, retinopathy vaicilla. So what is the first change? That is mild NPDR diagnosis annually.
Microaneurysms, presence of microaneurysms.
Yeah, that is the first one. So VSR is leaving. Thank you, sir. So VSR is leaving the same. Okay.
No,
so
no,
the first
8:30 meeting.
Okay. Thank you, sir.
Okay.
So what is the first change of diabetes mellitus in the retina?
Presence of microaneurysm.
Yeah. So first change you have to look into is the fovea. So is there any single microaneurysm? So if there is no, if there is fovea appears normal, most probably there will not be other changes of diabetic retina. Okay, so you're saying this is a case of primary open-angle glaucoma. So what is the diagnosis? I mean, what is the definition of primary open-angle?
Primary open-angle glaucoma is defined as an increase in the intraocular pressure more than 20. It's a progressive optic neuropathy characterized by elevated IOP more than 21 millimeters of mercury with characteristic optic disc changes and visual field changes.
Okay. Actually, you should say that intraocular pressure is only a risk factor. It's a chronic progressive optic neuropathy with optic nerve head changes and visual changes, and the intraocular pressure is one of the risk factors.
Risk factors.
Okay, what is the pathophysiology?
This is a multifactorial disease. Different factors are contributing. Some genetic predisposition is there, that is changes in the myocilin and the optineurin gene. Then two major theories is the mechanical theory and the vascular theory. The mechanical theory suggests that due to the increase in the intraocular pressure, it may cause compression on the lamina cribrosa, and there will be posterior bowing of the lamina cribrosa. The axoplasmic flow will be affected. This posterior bowing may also result in the blood flow, capillary blood flow, resulting in the decreased perfusion of the optic nerve head. Then second is the vascular theory, which suggests that the decreased optic nerve head perfusion is a reason for the development of POH. Other systemic factors like systemic hypertension, migraine, Raynaud's phenomena, all these contributes to the development of this glaucoma. Then, then additional secondary insult like glutamate toxicity, nitric oxide toxicity, etc. can also contribute to the pathogenesis.
Okay. Why do we say that venous occlusions can occur in a patient with primary open-angle glaucoma? What are the associations like patients with primary open-angle glaucoma have more risk of CR wave? What is the cause?
Because of the decreased perfusion of the
decreased perfusion. Again, a decreased perfusion. This is stagnation in the circulation of pus. When there is raised the episterial venous pressure increases, one stagnation in the veins occur. In addition to that, what happens? In elderly patients, also the arteries will have change. So arteries will also press onto the vein. This arteriosclerotic changes that occur in the artery will press onto the vein. Then there will be stagnation in the circulation. So all these will contribute, it can contribute to a venous occlusion in a primary open glaucoma. And also when the nervous support is lost, the veins are more exposed to the damage of the raised intraocular pressure. So that is one of the causes of CRV occurring in a primary open angle. So in your patient, what is the target intraocular pressure?
The target intraocular pressure is that pressure below which the further damage of the optic disc is not there. Further glaucomatous damage is not there. So it is determined on the basis of different factors like the presenting IOP, the age of the patient, the comorbidities, then the gender of the patient, etc. So in my patient, the target IOP should be in the low teens.
How
Because
do you assess? How do you calculate the target intraocular pressure?
it is calculated based on the presenting intraocular, presenting IOP and the
Why did you say she should come to the low teens? What was the first one was
because
26
based
and
on,
28, right?
yes, ma'am.
26 and 28. So
We
you have
can-
to, yeah.
We can classify the glaucoma as mild, moderate, and severe. In
Okay.
case of mild glaucoma, that optic disc changes is there, but no visual field defects are there. And in moderate cases, optic disc change is there, visual field changes in one field, but it is not in 5 degrees of fixation. And in moderate, severe cases, optic disc changes along with the visual field defects in both quadrants and within the 5 degrees of fixation. So in my patient, there is optic disc changes is there, visual field showing changes in single quadrant, but not
So
within.
show your optic, your visual field.
This is the HFA of the right eye of the patient.
Okay, what are we seeing in the right side? Oh, you are
Just
magnified the parameters are magnified.
parameters.
Okay, what are the different zones that we have to read in the HFA?
So the first zone is the patient details, that is the name of the patient, age of the patient, and pupil diameter, visual acuity, the refractive error correction factors, date and time, which eye. Then the second zone is the reliability indices, which gives the fixation target about the fixation loss, false positive errors, false negative errors, etc. Then we have the zone 3, that is the zone of raw data that we obtain from the patient. Then zone 4, that is the grayscale. Then we have the zone 5, that is the total deviation numerical plot. And in zone 6, we have total deviation probability plot. Then we have the zone 7, total deviation pattern deviation numerical plot and pattern deviation probability plot. Then we have got the global indices, which shows the VFI, mean deviation, pattern standard deviation.
Okay, so based on what you said, the central 5 degrees affected, huh?
Central 5 degrees are not affected in this condition.
So what is the target IOP? Is this a reliable field?
This
How
is
is
a
the how is this fixation loss monitored?
fixation loss is monitored using a heel cracker method. Patient is asked, the light intensity is given at the presumed blind spot of the patient.
Yeah. So you're putting a stimulus at the blind spot. And if the patient is able to understand it, that means there is a fixation loss.
Yes.
If it is a false positive, how is it checked?
False positive means that when the patient is clicking on even without a stimulus, that is the trigger happy patients indicate the false positive. It may be seen as white spotoma in the grayscale. Then we have false negative errors. That is, at a point where the patient earlier responded to a dim light, now if he is not responding to even a brighter stimulus, that is indicative of false negative. So false negative we can see as clover leaf pattern in the HFA.
So that if it is occurring in a glaucomatous patient, is it significant?
It is significant because this even in a very attentive patient, if it is glaucoma, this clover leaf pattern can be seen.
Yeah, so if the false negative percentage is more, if the patient is having glaucoma, actually we'll have to neglect that. Because in glaucomatous patients, false negative can be high.
Yes, ma'am.
So in this patient, I'm not very sure. I can't see clearly whether it is involving the central third 5 degree. But if it is like that, if it is not involving the central 5 degree, what is the target IOP?
In the middle teens.
Yeah, that is how much percentage decrease is expected? 20% decrease
Yes.
from the initial. So if it is like that, that means that your patient has achieved the target endocrine pressure
IOP.
because it is 18 millimeter. Can you show the next eye also? So here also it has not come into the 5 degree. It has not
Yes.
come into the central 5 degree. Okay, what is the criteria based on which you make the diagnosis of glaucoma?
That is the Anderson's criteria.
What is
It
Anderson's criteria?
says that in any case, if the 3 non-edge points in a field corresponds to a cluster of 3 non-edge points, out of which 2 is less than p-value less than 5% and at least 1 with p-value less than 1%. Then the pattern standard deviation with p-value less than 5%. Then the glaucoma hemifield test is outside normal limits in at least 2 different occasions.
What is this glaucoma heavy field test?
Glaucoma hemifield test means it is actually trying to find out the mirror image on both the hemispheres to see the how much of the field is involved.
The superior and inferior mirror area is checked. That is the hemifield test. So what is a hemifield test in this patient?
In this right eye of the patient, it is outside the normal limits, and in left eye, it is borderline.
Okay. So is it PSD or CPSD that is included in Anderson's criteria?
CPSD is involved.
It is actually CPSD. What is CPSD?
Corrected pattern standard deviation.
What is that?
The intensity of 2 different points in a field.
Pattern standard deviation minus the short-term fluctuation is CPSD. Okay. Can you show me our RNFL? What is the pachymetry of the patient?
Pachymetry of the patient is 536 micrometer in the right eye and 540 micrometer in the left eye.
Okay. What is the risk for glaucoma corresponding to a corneal thickness?
If the corneal thickness is high, the IOP may be overestimated, and if the corneal thickness is less, IOP may be underestimated.
So in your patient, is it high or low?
It is in the normal range.
520 is taken as normal. So almost 20 micrometer more.
So it is more.
Yeah, so you can give a decreased correction to your patient maybe. So anyway, it could be above anyway 20 for your patient. So if in all your primary diagnosis of glaucoma, what is the importance of doing a facing?
Facing or the diurnal variation of IOP. It is very important in determining the diagnosis of the glaucoma and also it aids in the treatment. That is, the IOP of the patient varies according to the adrenocortical or the catecholamine fluctuations in the body. It will be high in the mid-morning. As the day progresses, it will decrease. This is the most common pattern, but there are different patterns have been observed, like a falling curve, like it is most higher in the morning. As the day progresses, it declines, and then sometimes it is a rising curve. It is lower in the morning and higher as the day progresses, and double hump pattern may also be seen, like in 9 to 11 a.m. it is more, and then by 4 to 6 p.m. it is high. So the phasing is important in diagnosing the glaucoma and also in treatment of the patient.
But you didn't tell me when it is taken as positive. So you have to
If
check
in normal cases, there will be about 3 millimeter variation. But if it is a glaucoma, there will be 6 to 8 millimeters of variation can be seen in
Yeah, so
diurnal
what they
variation.
say is if it is more than 5 millimeter, you have to say it is positive. If the values have to be measured ideally during which period? So actually, most of the population, they have high IOPs in the morning hours.
Morning time.
So the morning time has to be included in your phasing till at least 3 to 4 o'clock in the evening. And the difference between the maximum and the minimum should come to more than 5. That is done in, that is importance of phasing. RNFL condition. So in your right RNFL, is there any abnormality actually? Right.
In the right RNFL, we can see a thinning in the inferior quadrant. And in the also there is a depression which is seen here in the inferior quadrant. And some borderline thinning is there in the superior and temporal quadrant in the right eye. Whereas in the left eye shows a thinning in the superior quadrant and some borderline thinning in the temporal quadrant.
What is this graph called?
Tisnet.
Yeah, it is called the TSNet graph. Okay, so it is corresponding to your optic nerve head changes. Is it corresponding?
Yes, ma'am, it is corresponding. In the right eye, it is corresponding. Yeah, left eye also it is. But I saw the inferior rim equal to superior rim in the optic disc. But here it is showing the thinning only in the superior quadrant.
I'm just wondering if there is a small displacement or whether it was centered correctly or not. I think there is a slight displacement. That is why you're not able to appreciate it correctly. Okay, can you show me the fields again? Okay, when you are looking onto the fields, what should make you suspect whether it is a neurological or a glaucomatous cupping?
The glaucomatous cupping always respects the horizontal meridian, whereas the neurological cupping, it respects the vertical meridian. Then in in neurological, we will see it as absolute changes, absolute scotomas may be seen, whereas in glaucomatous, we can see the progressive scotomas. Then,
so what are the other causes of non-glaucomatous cupping?
Non-glaucomatous cupping can occur in cases of other optic nerve head changes like optic nerve pit, optic nerve drusen. Then in case of AION, then whether the patient has got some lasers in the past. All these can also result in field changes.
Actually, I was not talking about field changes. Glaucomatous cupping, that characteristic cavernous cupping, which all conditions it can.
Can happen.
Other than it can occur in AION.
Yeah.
Can occur also in space occupying lesions. Then toxic ambulopathies, that is due to alcohol toxicity. That is one of the important causes you have to roll out. AION toxic ambulopathies, those are the most important causes. Now, this arcuate scotomas, you can get in other conditions. I think that is what you said. That is old lasers, PRP lasers. Then what else?
Optic nerve head drusen, optic nerve head pits. Then AION.
Then juxtapapillary choroiditis that occurs in tuberculosis. All this can cause an arcuate scotomas. Okay. So how will you decide the therapy of the patient? What is ideal of therapy?
It will be decided based on this target intraocular pressure of the patient. Like first of all, we will start on with beta blocker, and ideally we will prefer a monotherapy first, and we will see if the pressure is coming down or the patient is not responding, patient is responding or patient is compliant. And we will recheck the IOP after about 1 week. And if it is not coming to a norm within our desired target, then we will add on another medication with another mechanism. And we will see for the whether the desired target IOP is reached. And the endpoint, and we will also consider doing an HFA or OCT RNFL to see if there is any progression.
What is the indication of OCT or NFL?
6 months to see if there is any progression of the thinning.
OCT or NFL, ideally it's used only for the diagnosis of early
Yes.
glaucomas and also normal tension glaucomas, ideally.
Mhm.
Glaucoma progression software is available in the HFA. Then about regarding the treatment, which is the drug of choice?
Beta block prostaglandin analogs is the
It
drug
is
of choice.
prostaglandin
Glandin
analogs
analogs is the drug of choice.
Why we don't prefer beta blockers over prostaglandin?
It has got more systemic side effect. The
Yeah, it
beta
has got
blockers
more
has got more
systemic side effects.
side effects.
And actually, more than adding, they advise substituting the drug.
Mhm.
And then after substituting, still it is not reducing, you have to add.
Add the drug.
What is the MMT or maximum medical therapy?
Maximum medical therapy is that if the patient is achieving the target IOP with 3 different classes of anti-glaucoma medications, that over a period of 2 months, 3 different classes of anti-glaucoma medication, that is the maximum medical therapy.
3 and 4 and 3 and. Okay, so I think we have discussed a majority of all the things that has to be discussed. A very good presentation, and you have read very well.
Thank you.
Thank you.
Thank
When
you.
is your exam?
Next year, 2025.
Okay, so you have ample time to read the remaining subjects. Okay, then, thank you.
Okay, ma'am. Thank you.